So folks, welcome. This is going to be an initial overview of the National COVID Cohort Collaborative. Subsequently, we'll refer to it as N3C. And, you know, I wanted to just give you a little bit before we go into the slides of an overview. And really, the person to really thank for this is Wes Kimball. The idea for this came last spring. I think we were only a couple weeks into the epidemic in March, and he formed a COVID-19 registry through WVU Medicine and our IDR that really included anyone tested, whether the test was positive or negative. As you know, there are now 12 funded clinical and translational research centers, and you know, they were wondering what to do. And I said, we should have a consortium and have a registry among the 12 of us to really look at outcomes, particularly, you know, in rural areas and with special populations that include not only rural populations of color, but Native Americans to Native Alaskans. And actually NIH, and they're on our PI calls, love the idea. And they said, would you write a supplement to really with what you think you need, and for any sites, CTRs that want to do this. And the long and the short is that 8 of the 12 CTRs are involved, shown on the next slide. And we not only got the 600,000 we initially wanted, but we got another 400,000 with indirects. The entire award came to 1.5 million. And again, you know, without Wes really proactively starting this registry, we wouldn't be here. So N3C, it's a nationwide clinical database that is being established to look at data related to SARS-CoV-2. The data being submitted are harmonized and are available for researchers anywhere. And we'll talk a little bit later about what you have to do and how you get access. And this includes all our partner sites. The N3C is really a partnership among multiple NIH programs shown there and institutes. And again, the 8 participating CTRs are shown at the bottom. The requirement was that you have data in one of 4 formats shown there: OMOP, PCORI, Trinetics, or ACT. And they really take that, it's all translated into OMOP, it's harmonized, and then it's really sort of put into an engine that really generates 3 different kinds of data sets: synthetic data, limited data set, and de-identified, and we'll talk about those later. And this will be for the use not only of various investigators, but also the CDC, FDA, and other federal agencies. And I would invite Wes to just chime in anytime, and also Emily Morgan, who's just been terrific. As of the middle of November, there have been 66 data transfer agreements signed, and you can go through all the things there. And basically 27 sites, including our registry from WVU, have deposited data in the pipeline. The requirement is IRB, data transfer agreements, data use agreements. You know, it takes a little bit of time to do it, but our data now is in there. And, you know, currently you can see there are about 1 million total patients, of whom 120,000 are COVID-19 positive. I'm sure that that's going to be going up. And you can see there are really lots of data in there: lab results, drug exposures, visits, observations. So, you know, it's really quite a rich data set. It is obviously EMR. It is planned to, in the future, have images, though to my understanding, Wes, correct me if I'm wrong, that they're not currently images in there, but they are planning for that.
Yep, that's correct.
And you can see here just the demographics of the population in N3C. And again, this is growing. You know, there are 60 some CTSAs, all of them are supposed to be participating. You've got 8 CTRs, and then you have data from other organizations as well. So I think we're really still very early on, but you can see the demographics. I'm not going to go through them there. I mentioned earlier that there were 3 different types of data sets. One is a synthetic data set that is artificial but statistically comparable to the original data. It doesn't contain any identifiable health information at all. And you can see the eligibility. Really, anybody can use synthetic data. Use of any of these data sets really requires N3C registration, data enclave, account, data use agreement that's signed by your institution, some training, and we'll talk about all of these components. The de-identified data set really is patient data that's been stripped of PHI, and that really, in addition to the requirements for the synthetic data set, requires human subject training, city training. And then there's the limited data set, which also includes some elements of PHI, basically dates of service and patient zip codes. For any zip code that has less than 20,000 patients, you just get the first 3 digits. And some of the tribal nations and Alaska natives, you know, that will actually may not be available. But for West Virginia, we have quite a few zip codes that'll just be available as first 3 digits. And you can see that also, in addition to what's required for the other 2 data sets, requires local IRB approval as well. To get access, you have to register at N3C. You go in and there's a security training. It's you know, it's mostly common sense. Some of it is a little more centered towards NIH centric type folks, but it took me about an hour. And then subsequently you get access, and we'll go through that. If you want to actually submit a data use request, so, you know, submit a idea for a study, there's a form, and we'll address that in a minute. It's reviewed by a committee. And, you know, one of the things about N3C is, I'll talk about all the committees. You can explore actually the projects that are ongoing. And what they want is not a lot of redundancy, but if there is a project that is similar, you know, anybody is welcome to join. And it's really almost a very, very collaborative, I think, sandbox rather than an individual thing. When you check in to register for the first time, I mentioned you'll get a checklist. The security training is as I discussed, but the other pieces of information that you'll need is your ORCID ID, and then you'll have to download a 2-factor authentication. They will ask you if you have human subjects research training. You don't have to give them the certificate, but I suspect if you want sort of a data set requiring that, then you will need to provide that. So this is the registration login. You know, Wes and I were talking about this earlier. So the arrow here is on the login government account. I have an existing government account. It's actually interesting. I hadn't used it for a while. It was not my Commons login. And it actually took me right there. You actually have the opportunity to connect to a participating institution, and then they review over a period of a day or 2 and then send you access. Wes used the top, the login with an existing account. Do you want to talk about that, Wes? Because I didn't do that.
Yeah, sure. And that's probably going to be, you know, the way that most people are going to want to log in. you know, unless you do have a .gov account, but I think the top option here, log in with your existing account, is going to be more applicable to everybody. So what you're going to do here is sort of where you see the choose an organization box, you'll start typing West Virginia University, and it'll pop up a list, and you'll choose West Virginia University. So what the NIH has done for this is they have used the Federated Authentication method. So basically what that means is that since we have participated WVU, the NIH and N3C has worked with WVU so that you can actually use your WVU credentials to log in to the N3, to register for N3C and to log into the portal. So that's the way that I did it. And then it actually, so since I am in WVU's, you know, system as an employee, when I chose WVU, I started typing in my information. It pulled up everything. It already had it. And then of course, which for everybody on WVU here or WVU medicine, WVU uses duo authentication, and I'm blanking on which one the hospital uses, but those are approved. Both of those are approved authentication methods. So essentially what you do, you put your information in, it will, you'll get an email that'll say, you know, thank you. You will get an account within, I think they said 48 to 72 hours, something like that. I finished my training the other day at like 6 p.m. and I got my account by noon the next day using my WVU login credentials. And Glenn Beard here just chatted Improvada. Yes, Improvada is one of the accepted authentication methods. That's the one I was trying to think of for the hospital. So, and if anybody wants to do this, you know, and they have any problems, feel free to reach out and we can sort of go through it. But quite honestly, it was pretty simple. And it just uses all my WVU authentication to log in that way. So it's just like logging in to any other WVU system that we have.
We had another question from the chat. I'm sorry to cut you off. Do you know if the in-common login will work for Marshall users the same way it does for WVU?
I think I don't know that for a fact, but I think it should. But here's what I was going to say. They require whether or not you submitted data. So Marshall is a good example. Let's say there's an investigator from Marshall. So Marshall University is obviously a, you know, separate institution, and they would have to get a data use agreement signed to use from Marshall. So that the only caveat here is the WVU agreement is only for individuals that actually are WVU, you know, credentialed and faculty. So if you're not WVU, if you're at CMC or SOM or Marshall, you can still use this, but you do have to get a data use agreement. And they do have a page where it says, you know, on that checklist, the data use agreement, you can go down and look at participating institutions. If yours isn't there, then it has a place to actually procure the data use agreement. And if anybody from another institution, from any of our partners, has any questions or problems about that, you know, please get in touch with Emily and you know, we'll help you. It's not hard to do. Obviously, you have to take the data use agreement. It takes a while. Your institution has to sign it and you have to submit it and get it executed. But it's not a long process. I don't know, Wes or Emily, do you have anything to add to that?
No, that's right. I'm very familiar with data use agreements and sort of the legal procedure that they go through. So if anybody on the call is not that familiar or your institution doesn't do a lot of them, I'm more than happy to help. I will say though that one thing, because I'm sure there are a lot of folks on here who have had to do a data use agreement before to share data. With this one, we are executing an agreement, an umbrella agreement with the institution. So that would cover anybody within our institution to be able to access the data. However, if you want additional data, that's where the individual researcher would sign the DOR that Sally spoke about. So as long as the institution has a data use agreement, you don't have to have a specific DUA per each investigator.
Yeah, and the DUR is if you want to sort of submit an idea for a project, but to even register, you need, you know, a DUA. And West Virginia University is listed. There's a whole big long list. I didn't really look at the whole thing. Okay, so once you get registration, so once you sort of get that back and they've registered you, then you have access to the enclave. And the N3C enclave is a secure platform which the harmonized data are provided to contributing members. It can be accessed through a secure cloud portal that's hosted by NCATS. But the thing about it is it can't be downloaded and it can't be removed. I've got to say, and for those who really want to get into this, we're going to have a follow-up probably in December, a bit more involved about what is in the enclave. But I can tell you that it is not an easy, sort of front door like Trinetics, where the analytics are just very easy to use. This really requires some coding. They have R, Python, but it also requires some Spark. And even the data folks, that we've been working with across the CTRs felt that this was quite complicated. I will tell you that I'm actually suggesting that they want clinicians to use this. Trinetics is involved. And in my opinion, they need to really put a user-friendly front end on this, which it doesn't have. Nonetheless, actually $1 million, the NIH has put $1 million in for support specifically for CTRs from the CD2H, Clinical Data to Health organization, and the University of Oregon is really in charge of all the training. They are very nice. They're very accessible. My feedback to them has been that I think that they really anticipate that these are the users are all people who are data aficionados, which, I'm not speaking for anybody else, but for myself, I'm not. And so, just be prepared for that. But nonetheless, the analytic support is there, and we will do, if you're not getting what you need or it's not understandable, we will absolutely facilitate connection to Oregon in the training group. When you get in the enclave, there are a whole bunch of buttons, as you can see there. What would you like to do? We talked about a data use request. The data use request is there. It's a pretty straightforward form shown there. I'm not going to sort of read through it. You need to sort of specify whether you want, which one of those 3 data sets you want, the synthetic, the de-identified, or the limited. And I can tell you that if you want the limited data set, then you have to have a rationale for why you need those data, the dates of service and the zip codes. We're actually working on something across the CTR where we do want the zip codes because we want to look at outcomes in different parts of the country relevant to various types of therapy. So, don't, think about what you really need. De-identified is obviously, I think, much easier to get. And if a synthetic database will meet your needs, that is the easiest of all. I don't know, Wes or Emily, do you have anything to add on that one?
Yeah, I would just like to add something to the synthetic data, because sometimes that term gets folks tripped up because often they want to look at dates, things like that. Oftentimes a synthetic data set will 100% satisfy your needs for when you're doing an analysis using, for example, dates. Because what we do is you would actually get dates, but they would be obfuscated from the actual date using an algorithm only we would know. So if you want to look at length of stay, for example, the true date might be, let's say, 11/20/2020, which would be when the patient was admitted. But in the synthetic data set, we're going to obfuscate it. So we could offset that date plus or minus 7 days, plus or minus 10 days. So at the end of the day, when you actually do your analysis, the length of stay for that patient is still going to be accurate. You just will not have ever gotten the actual true date.
Okay. I don't know, I can't see the chat. So Emily, if there are questions as we're going, please.
Sure. So it looks like we have one question left that is outstanding, and they would like to know, are social determinants of health included in the N3C?
Some of them are. Race is, though there's some obfuscation about, tribal communities and so forth, and Alaskan natives. There is not, to my knowledge, any sort of, income that is not in there. I am not sure about insurance. I think it is, but we can check that for you. And then, of course, one of the important issues that you can sort of look at is obviously the zip code is where that person's located. Is it rural? Is it, where's it located? So that, to my knowledge, is what is there. When you get into the enclave, you can actually sort of look at all of the things that are there, the components, and sometimes that's really helpful when you're sort of forming your question that you want to ask.
So another question that's just come in, are there any regions of the US which are not represented or underrepresented in this cohort?
Well, as it's just being put together, they anticipate that this is just an early extract. One of the concerns was that actually rural areas were underrepresented, which is why they brought in CTR, which by and large has more rural areas. I don't know. I think Hawaii's in. I don't know about Alaska. And obviously, most of the data is going to depend on two things. Obviously, urban centers, because there are more CTSAs there, and because early on the epidemic was centered in urban centers. But more recently, obviously, with the explosion of COVID in rural areas in Middle America, you will then get many more cases there. Remember, it's a function of, do you have a center that's contributing data and tests that were done? If there wasn't much testing, there won't be much there. So this is refreshed frequently. How often are we sending a refresh, Wes?
So we are currently, we actually have got some pretty good technical questions in the chat. So there are some technical folks on the call. So just as a little background, the CTSI's data, we used to be on I2B2, for those of you that are familiar. Within the past year, we've moved to the newer OMOP data model, and that is actually the preferred method, because that is what the eventual N3C database is built off of. I got a question, does N3C accept PCORDnet? Yes, they do, but it eventually gets transferred to OMOP. CTSI, we are on OMOP, so that's how we transfer our OMOP, our data. We transfer it from our OMOP database here to Trinetics, and Trinetics feeds the data to N3C. So that kind of kills two birds with one stone for us, because we're on Trinetics as well. So not only have we now refreshed Trinetics with the load, we've also refreshed N3C. We've currently sent 2 refreshes. We are looking, currently the process is a little bit more manual than we would prefer. So we were looking at, I think, monthly for now, but we are working on an automated fix so that we could do it probably weekly. And that is our sort of next step, what we are working on, my team is working on to do, so that we can get much quicker refreshes. And those would also go to Trinetics as well, for those of you that use Trinetics. So we would refresh, and not just COVID data, but everything.
Are there any other questions? Or should we move on?
Doesn't look like anything else has come up in the chat.
Okay, let's move on a couple more. I mentioned there was a button to explore projects, and this is just a screenshot, giving the title and sort of a research statement, what it's about. as I said before, if you see something there that's really interested and you want to do something close, but you have a better idea, you can actually ask to join, and they have lots of teams. I mean, that's sort of part of the idea. If you submit a data request that the data review committee considers to be very close to an ongoing project, you may be asked to join another team. As you can see, this is really team science. It's really, a lot of collaboration. And, I think that it's an interesting model. When you actually sign up, as I mentioned, you need your ORCID ID, and they want to make sure that they really sort of have credit for folks that really are involved in all of the, in different projects. In addition, there are other ways to get involved. There are work streams that are shown there. And then there are clinical domain teams. And these are clinical domain teams that exist. I've actually just applied to add a rural domain team. So we'll see how that happens. But, and you can join, you just click and are welcome to join any of these. It is not something that, you have to apply for club membership or something. So, if you're doing, we have, for example, an investigator who's doing a clinical trial on acute kidney injury. That might be actually quite a good domain team to be involved in, not only, to sort of see what the research questions are and provide expertise, but I think also, to really understand what you can contribute. And they're really, really looking for folks to be involved in these and to expand them. And I think that's the last slide.
So we have another question in the chat. They're wanting to know, would N3C keep up with the therapeutic outcomes for new vaccines?
Actually, that's an interesting thought. Currently, if the vaccine is in the medical record when they come out, and obviously the clinical trials are blinded, so we would not know that at present, but clearly I'm sure that they would want that to be in. They are keeping up, though, with all of the therapeutic advances, including the monoclonal antibodies, which I think are going to be important. So we'll see how once the vaccines really sort of get into general use, if it's in the EMR, it'll be there.
Yeah, and I just want to point out that these data, I know just from the presentation, it sounds kind of high level sort of data, but it's actually very granular. The phenotype that we use, we've got so many lab results, we've got vitals, it's actually a lot of different variables that are able to be extracted from that data set. I think each time we do a load, I think we loaded 140,000 patients last time and probably 50 million data points. And that's just from our WVU medicines or the CTSI's COVID database. So you can imagine, multiply that by 30, 50 sites, how much data is in there, especially outcomes data, hospitalization data, ventilations, procedures, all that's in the database.
Yeah, and I would say, you mentioned the phenotype for being entered is a test, whether it's positive or negative. So any COVID test, and as we showed to start with, about 80% of the folks in there currently are COVID negative, in there as negative. And the data actually start for all of the accepted phenotype, if you're in there, at 2018. So, really you get data from before COVID started for baseline comorbidities and so forth.
So we got another, this is actually a very good question that Sally and myself and many others have talked about. So the question is, what is the future of N3C post-COVID-19?
Well, I mean, who knows, but NIH, this is what I have gleaned, but you have to take this as my personal opinion. It is not an NIH statement. my opinion is I think they've wanted to do this for a long time and have never really had an emergency that really could provide the funds to do this. This is an expensive thing to do. I mean, just if you just look at the CTRs, it's 2.5 million, and that was not developing any of the infrastructure or so forth. I think it would be hard to believe that this will just stop with COVID, though I think COVID is going to have impact for years to come on people. So I think that the long-term impact of COVID, this database and this project will be very good. But I think in the future, this is the trial run to really look at granular, large national databases through the NIH that are really sort of very carefully curated and harmonized to look at a number of different conditions and outcomes and populations. But that NIH has never stated that I've heard.
So we don't have any other questions in the chat box, but anybody have any other questions or?
I have a quick question.
Sure.
If I'm not interrupting anyone. So Sally, because there's so many institutions contributing to this amazing cohort, I'm wondering if there are some plans to somehow incorporate the service areas that these institutions serve. And I guess what I mean by that, if I could clarify, is like here, WVU Medicine serves the southern counties of West Virginia, but because there are less services, our data really potentially isn't representative of what's actually going on in the southern part of the state. So if someone wanted to include West Virginia data, let's say in a multi-state study, they would need to know that, right? They would need to know that there's potentially a bias, that our data doesn't cover a lot of the southern part of the state. Is there any talk about that, or is this something we thought about?
No, I mean, that's a good question, Brian. I think that every institution, obviously, there are always biases about where those data come from. I think, looking, I mean, you're the geospatial guy, looking at actually an institution's distribution of where those cases come from, I think will tell you one thing, and that is possible. Obviously I said there are constraints about if you have less than 20,000, and you would be amazed how many zip codes in West Virginia have less than 20,000. I was pretty shocked when Wes pulled that up. But nonetheless, I think even with 3 digits, you get a very good idea. There are opportunities for consortia. For example, within N3C, we've developed a CTR consortia, which, and you saw the participating CTRs, many of them address rural populations. And we are actually looking at a project among our consortia, and then also comparing with the rest of the US. So I think there are a lot of opportunities, but I think that's one of the limitations. And I think it's really something you have to keep in mind. Your work looking at RUCCAs or, sort of areas of deprivation, are very different even throughout West Virginia. And it would certainly be interesting. One of the problems with the enclave is making sure, for example, that you can bring other tools in. And that's something that I think we're going to have to work through with them. But I think that'd be really interesting.
Yeah, I think it's also something that we could do as a group. Any of the institutions contributing state level data could say, hey, this is roughly our service area, or there could be like a cautionary statement when you're pulling the data saying, hey, just so one of the limitations of this is potentially, we don't serve populations equally, right? There are service areas. The other thing is, typically 3-digit zips are larger than counties. So has the consortia looked at sort of how many counties fall into that 20,000 persons threshold? Because counties are typically smaller than 3-digit zip.
We looked, Wes pulled up the list, though there were a lot more than, I didn't look at how many of those 20,000 or less zips, had more than one county. But there were a lot of zip codes even in West Virginia. So, I mean, we could find that out, but we don't know. I just want to be clear though, anybody, so WVU, to my knowledge, is the only institution, WVU Medicine, that has contributed data. And it's WVU Medicine and you know, sort of, that's beyond Ruby and Morgantown. Now, you know, if you're at an institution that is not contributing data, you can still use this. And I think that's one of the beauties. We've had, you know, a lot of requests, well, you know, we want to use the IDR and so forth. Well, this actually really facilitates that. On the other hand, if you're at an institution in West Virginia and you want to contribute data, you know, you can, there is a facility to be able to do that if your institution will let you do that. You have to sign a data use agreement and a data transfer agreement and so forth. And that data use agreement is obviously different than the data use agreement where you're just using N3C data in the enclave, you're not contributing data. So I just want to be very clear that if you've not contributed data, that's okay. That is not a limitation to use this.
I do want to highlight that Jandy Handa from the School of Osteopathic Medicine mentioned in the chat that they have turned in their DUA yesterday. And so they're just waiting for that to be executed now. So we do have at least one other site in West Virginia who is joining.
So we've had a couple really good questions in the chat. One of them from Glenn Beard. He says, this is probably a basic question, but what exactly does curation and harmonization entail in terms of data alteration editing? That's not a basic question. It's complicated, to be quite honest. So WVU Medicine, we have, I think, 11 sites we own and 2 sites that we manage. So that's 13 sites. Most of them are on Epic or they are coming onto Epic. Just because WVU Medicine has Epic does not mean, say, LSU, who, and I'm just making this up, they may not use Epic, but if they do, that does not mean that our instances of Epic are the same, nor are our databases the same because of the way they were built. So what happens in this situation? So what my group has to do is log in. We abstract data from the back end of the Epic. So Epic is just a front-end user interface. The data actually lives in a huge data warehouse of over, I can't even remember how many tables. It's enormous, but it's called Clarity. So we abstract all of our data from Clarity using SQL coding. And then we will so it's called an ETL, extract, transform, and load. Now, when it comes to the curation, that's the curation part. We got to get the data out of our electronic medical record systems. Now, back to going back to the differences in EMR instances, it would not be useful for the overall N3C if WVU sends in our data and LSU sends in their data, as an example, and we have different lab codes for the same lab. Or we had, you know, the way that we code male versus female. Maybe some people put actual MALE, some use M. So what that is what the harmonization piece, that's where that comes in, okay? So N3C luckily is able to handle that, because if we had to do it on a site-by-site basis, it would just be very difficult. So what N3C does once we feed our data into there, that's the purpose of the OMOP, the Common Data Model, to ensure that everybody's using the same lab code, like a LOINC code, a national standard. When we look at lab values, we're actually using the same lab value range, because that's very important if you're going to look at outcomes. So that's where the harmonization and the alterations sort of come into play. So although it seems simple, it's not a basic question at all, Glenn. And there's a lot of work that goes into the back end of making sure that that data is the same across all sites in that larger database. Otherwise, it would just be unusable. There would be no need to have this data if it weren't all using the same language and the same vocabulary. So we just have to make sure that every site, this code means the exact same in every other site.
Well, and I think you can start to appreciate the investment that they've had to make in this, you know, to sort of really make sure that you get, you know, harmonization that really is good. Otherwise, it's useless. So
Yeah, yeah.
I
We have some more questions.
yeah, do they have behavioral health data as well? Yes, insofar as ICD-9 diagnoses are included and medications are included. So, you know, if there is a diagnosis of depression or bipolar disease or something, you know, it would be there. If it's there as of 2018 or before the onset of COVID, you know, would be before. So that is there. To my knowledge, that would be, you know, the only data other than medications that you would be able to glean behavioral health data.
Then the other question from Global Engagement. Geocoding of the data for younger COVID-19 patients like students would be a challenge. How do you see that accomplished in N3C? Luckily, on our call, we have a geocoding expert. So Brian, sorry to put you on the spot, but do you have any opinion on that?
Well, I have a couple ideas. I don't know if they're strong opinions, but certainly, you know, Sally mentioned that they have zip code, 3-digit zip code. I think hopefully it'll have county. If not, you know, you could probably aggregate zip code to county. You would, in this case, you would probably just aggregate case data to the lowest spatial unit possible to have, you know, greater than X number of cases. I don't know, Wes or Sally, is there an agreement from the consortium or the group about what is sort of the lowest cell size? What's the small sample size for a cell? Is it 10 case? Is it below 10 cases? Is it, you know, below 20 cases? That would sort of determine what spatial scale you would aggregate data to.
So we do go by the safe harbor method for de-identification and things like that. So what happens is there's a less than 10 rule, right? So if there's a specific group of individuals that, you know, have rare diseases or something like that, if the number is less than 10, it's going to show you a 0. Now, if it's between 10 and 20, it could give you a number anywhere in between that when you're looking at number of these individuals. So, and that sort of, you know, is a standard method of de-identification of patients with rare diseases.
I mean, certainly the other thing you could do, if it would make it very hard to interpret your results, but you could, if you had the zip code level data, you could even combine, you know, 2 or 3 zip codes together to get the population size you need to comply with the rules and regulations. It would just be that when you visualize the map, it might be really hard for someone to understand, for example, a big group which contains 26505, 26506, and maybe 26501. You know, you might have to do some explaining there.
Yeah, the other thing I was going to add is remember, this will come, the zip code will come from the address in the EMR. Now, students may give their address, for example, if you're a WVU student here, or if they're from New Jersey, they may give their New Jersey address. So I don't think we know. I think, again, that's a limitation. And on the sessions I've been in, that has not been specifically discussed. I don't know if Wes has had discussions about that.
No, and that you know, that complicates it a little bit as well when you talk about students, because they're covered under students actually are not covered under HIPAA law when it comes to their health care, as it comes, if their health care is given via like student health, for example, they're covered under a different law called FERPA, which is actually more stringent than HIPAA. So if a student, for example, was diagnosed via student health or something like that, we're probably not going to feed that data. But if a student, you know, visited the ER as just a patient and not a student visiting student health, that's a different situation. So there's lots of nuances with when you talk about HIPAA data uses and things like that.
The other
that we
thing
have to
before we switch topics, the other thing I wanted to bring up about zip codes is that, especially in rural areas, you're going to have to be really careful that they're not PO boxes, because PO box zip codes can't be visualized in space the same way residential zip codes can be. So, you know, with hospital billing data, there are a lot of PO box zip codes, particularly in West Virginia. So, you know, you'll have to come up with strategies for that too. But there are strategies we can talk about at some point.
I mean, see, this is why there needs to be a rural domain. There's a question, it's interesting. It said when information for false positives like antigen testing be included. So any COVID test, or I didn't say this before, or if you've got an ICD diagnosis, ICD-10 diagnosis for COVID, those would count. But if an antigen is positive, that would count as positive. And actually the same is true with the data we're looking at, you know, with the state. So you can have antigen, you can have PCR. We're not counting as acute infection, obviously serology, but that is there. And there's been some talk with N3C about, oh, the lights just went out on Wes. There's been some talk about, you know, looking at serologic results as more of them come in. So, but the problem, the nice thing is, you know, those are a specific data field. So you can separate PCR versus antigen, you know, and so forth.
Yeah, and that's a good question to follow up on. The database does contain both qualitative and quantitative lab results.
Wes, could you give an example of what a qualitative lab result would be?
Let Dr. Hodder, she's the physician.
Yeah.
Well, no, this was, you know, if it's just positive or negative, right? And often PCR, the quantitative one would be the cycle time, right? The fewer cycles that it takes to see it, the higher viral load you would have. But, you know, just if you have a PCR that's positive, that's qualitative. And that was initially a bit of a glitch with our data, wasn't it, Wes? You know, we had to make sure they understood that.
Yeah, it was. And we actually had a little bit of trouble via abstracting it in our system, but that's why we actually just did another load last week, a successful load to make sure that those were included. And we just refreshed the entire database then. So, you know, within N3C, we are up to date as of like Friday. So we're pretty up to date on all of our results and things like that.
That's interesting that you brought that up. I mean, that's a potential tool to look at false positives. You know, if you have, you know, 0, 1, you're positive here, but maybe it took a high number of PCR cycles to get that positive, then that may not be a true positive. Whereas if the positive appeared earlier on in the cycling for the PCR analysis, you know, it's potentially more of a true positive.
Yeah, but I don't think the cycle times, and I could be wrong about this, I don't think the cycle times are in EPIC.
I see.
I think it comes a positive or a negative. I mean, you know, the same, if to take another example, HIV, you could have a viral load of, you know, 50,000 copies, or you can have a positive Western blot, right? So that would sort of be the difference.
So there's another question from the chat. Is the database equipped to capture genome level sequence information?
To my knowledge, this database is not. However, there is another project that is looking at all of the sequences of coronavirus. And actually, I don't know if Gordon Smith is on or Tim Driscoll. Tim, I know, he had a question about this a couple of weeks ago relevant to something else. But the idea is looking for the evolution of the virus. In N3C, not that they couldn't do it, but to my knowledge, currently they aren't. And in fact, you know, most people who have COVID-19 are not going to have their viruses, you know, sequenced. So I don't know, is Gordon or Tim on? No? Okay.
I believe they were earlier, but I think Gordon's hopped off.
Okay. Yeah, there were only actually, just to go off on a tangent, only 2 sequences from West Virginia cases of COVID in that database. Now, this was as of a couple weeks ago, so it may be more now. And, you know, we were really looking to try to get more sequences just because, you know, if you look, you can see, is this virus, you know, really changing? And if so, where, and what is going on in your own neighborhood? So that, I think that's an important project, but it's not this one. So I don't see any other questions. What we are going, this was to be a general introduction. I would urge everybody to register, get in the enclave. You've got to be in there and play around to really, I think, understand the next level. And what we're sort of planning to do next month is to get some folks from the CD2H Training Center and, you know, really to do a bit of a deeper dive on, you know, using N3C. And I would suggest that please, you know, Emily, I'm going to offer you up here, my apologies. But if you have, as you get in there and you have questions, some of them Wes and Emily could just answer quickly. If it's something you need to have answered, we can certainly, you know, connect you with the training site or get an answer for you. But if it's something you think is interesting, you know, bring some questions next time. And what I was going to say is email them to Emily ahead of time so we can make this a more useful, you know, sort of second session that's more in depth. But you got to get in there before that session to kind of see what you're doing, you know, or it's not going to be meaningful.
Yeah, and actually we have, for those of you that maybe do have more of a technical background in these kinds of things, we'd be more than happy to give a more technical presentation. But like Sally said, this was just an introduction, but we're more than happy to set up something separately to really get into the kind of weeds with you if you want to. Also, you know, should have done this from the beginning, but I would like to introduce Sharon Patrick on the call. She is the, she just started last week. She is the N3C coordinator, and she helps us to sort of coordinate amongst all the different sites and get our data together. And she's doing great, and she's just getting up to speed, but she's getting there quickly. So, you know, remember her name, because I'm sure you'll have a lot of contact with her as well.
Yeah, and the thing is, you know, sort of, Sharon's so new, and I didn't want to start offering up her name, or she might just quit tomorrow or something. But if you see something from Sharon, I mean, you know, there will probably be somewhat of a handoff with some of those questions from Emily to Sharon. So we are really delighted to have her.
Does anybody have additional questions? I mean, feel free to go off mute and ask a question. You don't have to ask in the chat box. Still got a few minutes.
Jim Denver has a question. I don't, oh, there he is. Is next strain the database you were referring to? Honestly, Jim, I'm not sure that was the name. Tim Driscoll was the individual, and, you know, he's doing some of the wastewater work around West Virginia, and I could easily ask him. But he was a little miffed that there were only 2 sequences from West Virginia in there.
Yeah, I'm familiar with a couple of different sequence databases, and they collaborate. And there's GIS8, which is more of a front end, and then Next Strain is a more general viral sequence database. They do have sort of a couple of 100,000 different sequences in there, but yeah, I don't think we've been participating very heavily in that.
Yeah. We should. Do you know what you have to do? Is it just, you know, sending the isolate, or do you sequence it here and then just send the sequence?
You have to sequence it and send the sequence. I asked that at a conference recently.
So, Jim, is that something you're doing?
No. The issue is that our genome sequence lab doesn't have the biosafety clearance to do something like that, unfortunately. So there's quite a lot of regulatory hurdles to jump through to make that happen. Okay.
All right. Yeah, I you know, I can find out. Obviously, they've opened the BSL-3 here for SARS-CoV-2 work. And I know that, Tim has been doing some sequencing on wastewater. I don't know what facility he's doing that in. So,
Yeah, I mean, it should be feasible. It's you know, just the usual red tape.
yeah. Okay, folks. Well, listen, you have our names, you have our numbers. We're going to send out the slides. We're going to tape it on YouTube. There'll be lots of questions, but you got to get in there and play around and let us know what we can do to help. And we'll look forward to seeing everybody back in December.